Now we'll call our next expert is Wes Moore, who is going to confront Bill. And his position is endarterectomy is best for most symptomatic and some asymptomatic carotid stenosis patients.
Thanks very much. Frank, thank you for the invitation, and congratulations for once again putting on an outstanding meeting. My disclosure is that I'm a co-PI for the National CREST trial. And this just is to remind you of the prospective randomized trials that were done in Europe and internationally, and to point out that a meta-analysis clearly demonstrated a favorable outcome with regard to carotid endarterectomy. Let's talk about CREST, and we'll go right on to the composite endpoint of death, stroke, and myocardial infarction. 4.9% for carotid endarterectomy, 5.9% for CAS. This difference was not statistically significant, and as CREST investigators, we're very proud to point out that these are the best results in the literature. However, we need to look at what I would consider not really a design error, but an error of analysis, and that is it appropriate to simply add up the primary endpoints? Each of these primary endpoints clearly are important, but when you just do a simple arithmetic addition, what you're saying is that death equals stroke equals MI, and at the extremes you're saying that there's no difference between a minor MI and death, which is really preposterous. So all primary endpoints are important, but they should be weighted according to their severity, and we didn't do that. You've already seen Bill Gray show this slide clearly from a patient's perspective. There's no doubt that major stroke and minor stroke are important, and they're important at the end of 1 year. At the end of 1 year, those who suffered a myocardial infarction, at least from their personal perspective, it was a non-event. So let's look individually at the important endpoints. And I would submit that the reason that we're doing carotid endarterectomy is to prevent death and stroke from carotid bifurcation disease. So let's look at death and stroke. And in carotid endarterectomy, there was a 2.6% event rate versus a 4.8% event rate in CAS. That difference was highly statistically significant in favor of carotid endarterectomy. Dr. Gray has already pointed out the importance of myocardial infarction. Here are the real data. 4-year mortality comparison, depending upon whether or not you had a myocardial infarction or a stroke. If you had a myocardial infarction, indeed this is an important endpoint because 19% of patients were dead after 4 years compared to 6.7% among those who did not. But look at this. If you had a stroke, and this included minor stroke, your 4-year mortality rate was 20% versus 11.6% if you did not. So I would submit that the survival benefit perceived in CAS with a lower MI rate is offset by the higher stroke rate in CAS, and therefore the higher stroke rate in CAS places the patient at a double disadvantage because they not only do not have a benefit with a lower MI rate, they have a disadvantage because of increased disability from the stroke compared with CEA. One other thing that's important to point out is that we had the best of the best interventionists. 427 interventionists applied for approval. Only half were actually approved, so therefore we had the cream of the cream. The question is this highly selected group applicable to the community? How do these procedures compare in community practice? Let's look at the SVS registry comparing CAS with CEA. And even if you add up stroke, death, and MI, CAS is 7% event rate in the registry, twice as it was in CREST, versus 3.75% with carotid endarterectomy, almost identical with CREST, and that difference was statistically significant in favor of endarterectomy. CAS is more expensive. Here are the National Hospital Discharge Database numbers. For asymptomatic carotid lesions, CAS is a third more expensive. For symptomatic lesions, it's twice as expensive. So I would simply say that CAS has twice the death and stroke rate compared with endarterectomy. CAS costs more than CEA. And the question is CAS likely to improve? And I would say, yes, it will. But in order to do that, we're going to have to think outside the box. And there's some anatomic considerations. Clearly, the object of our interest is the carotid artery, and that happens to be in the neck. It's not in the groin. And the box that we've found ourselves put into is that since most interventional procedures are done through a transfemoral approach, it automatically got translated into treating the carotid artery. When you do that, you buy disadvantaged arch anatomy, and you also increase the risk of embolization. I would submit that if you simply go back to a transcervical approach with CAS, you're going to bypass the arch, you're going to reduce your embolization, and you have the opportunity to use flow reversal as a better means of embolic protection. Thank you very much for your attention.